Good morning, everyone. This is Becky Royer with the Indiana Hospital Association and the Medicare Beneficiary Quality Improvement Project lead for the State Office of Rural Health. I want to thank Allie Orwig with the Indiana Rural Health Association for supporting Zoom for us today. We have a great program in store. So as we prepare for the program, I'd like for you to open up the chat function by hovering at the bottom of the screen. Please chat in any questions, or if you open up the participant icon, you're able to unmute your line next to the microphone beside your name within that participant list to ask some questions as well. We will have you, everyone muted here at the beginning and during the program to cut down on the background noise, so you will notice that you're already on mute. The presentation for today's program was sent out yesterday morning. If you did not receive it, let me know and I will get it to you with the recording link for today after today's program. So again, thank you so much for joining. I know how tired everyone is and working short staff, so it's great that you could be with us here today. Very honored and very pleased to have Dr. Arjun Srinivasan from the CDC. His bio was also included with the presentation. It's a very impressive bio. Some of you may remember Dr. Srinivasan from presenting for us in the past. For 2 years now, he's provided an update for us annually here in January. And a few years ago, he came to Indiana and shared with us during a critical access hospital convening meeting. So we appreciate his ongoing dedication for assisting our Indiana critical access hospitals. Arjun is the Associate Director for Healthcare Associated Infection Prevention Programs at the CDC, and he oversees several CDC programs aimed at eliminating healthcare-associated infections and improving antibiotic use. Dr. Srinivasan does need to be off the call today at 11:30. So if you have questions that we aren't able to address today, I will coordinate with him and we will get answers right back to you. So Arjun, I'll go ahead and turn it over to you so we can get started.
Fantastic, Becky. Thank you so much. And thank you all for giving me this time today. As Becky said, I really do recognize and appreciate that all of you are exceptionally busy right now, pulled in a lot of directions, and it just speaks volumes to your dedication for improving antibiotic use that you would take 30 minutes and join this call today. So sincere thanks to all of you who were able to make time to join today or to listen to this on the recording. I don't have any financial disclosures, and let's get right in. And this will come as news to exactly zero of you. COVID has had a major impact on our ability to do antibiotic stewardship in our hospitals. This is a very nice survey from Valerie Vaughn, where they surveyed a bunch of hospitals in Michigan, and you can basically see that essentially every hospital here said their stewardship activities were either somewhat decreased or significantly, strongly decreased during the COVID pandemic. And I think that's probably even worse now when we're in the midst of the Omicron surge. At the same time, what we have seen, and let me move this to the top here so that we can, there we go. We have seen tremendous progress, continued progress in antibiotic stewardship implementation in the United States. And so this is data from the annual NHSN survey, where we survey all hospitals on implementation of the CDC core elements. And as you can see, over time, we have made annual year-over-year progress. A little bit of plateau to be expected when you get very high numbers, but in 2020, nearly 91% of US hospitals indicated that they had implemented all 7 of the CDC core elements. And when you go back to 2014, not that long ago, right? Over 6 years, we went from 41% to 91%. So a really, really big increase, and more than doubling. And that's been fantastic to see that people have been able to maintain that growth. And when you look at the individual elements, what we see is that there are another 6% of hospitals that have 6 out of the 7 elements. So they're just missing one of the elements. And so when you add those together, right, we've got nearly 97% of hospitals that have 6 out of the 7 core elements. So I think we've built in this country really, really good stewardship infrastructure in our hospitals. And one of the areas where I have been kind of most proud and most pleased is the progress that our critical access hospitals has made. As you can see, if we go back to 2014, we were at 19.6%, basically 20% of critical access hospitals, right? So our critical access hospitals were 50% lower than the overall average. Go forward to 2020, we're at 83% of critical access hospitals that have all 7 of the core elements in place. The critical access hospitals have made the biggest gains in the country and now are basically pretty much right in line with the overall numbers. So fantastic progress. And I know that this slide is a reflection of the work of so many of you. You know, you are the hospitals that have done this hard work to get us where we are in the critical access setting. And so that is fantastic to see. And what's also wonderful to see is that we're not only seeing more hospitals with all 7 of the core elements in place, we're also seeing more advanced and stronger implementation of the core elements. What we know is that stewardship programs that are co-led by physicians and pharmacists are the strongest programs. Those are associated with the best outcomes and the most effective implementation of interventions. Back in 2015, about 23% of stewardship programs were co-led, and now in 2020, 63% of stewardship programs are co-led. So we're not only seeing more hospitals with stewardship programs, we're seeing more hospitals with better stewardship programs. So that is fantastic. We know, though, there are still places where we can make some improvements. And in particular, I'm drawing attention here to the action, some of the specific implementation strategies. And the circle is drawn around the 2 action strategies. These are the 2 strategies that we know are the most effective for improving antibiotic use, prospective audit and feedback, and prior authorization. And here you can see the green bars are the percent of implementation. So we're doing well here, but we still have some room to grow, right? About 70% of the hospitals have prospective audit and feedback, about 50% have prior authorization. These are the 2 most evidence-based stewardship strategies. And so we would like to see at least one of these in place at every hospital in order to improve antibiotic use in the most evidence-based way. So this is an area where we do have some opportunity for growth and some room for improvement. So we know, I'm going to move this to this, move this bar to the side again. So we know that many of the items have reached very, very high levels of implementation, right? For the individual elements, we're way over 90% for each one of them. And I think it does then create that opportunity to say, well, what comes next? Once you have a measure that gets to the point where it's, quote, topped out, where everybody is achieving very, very high levels of implementation, I think there's the opportunity to say, well, what comes next? Where do we go next from here? And, you know, in the revision that we did to the core elements in 2019, we did note a variety of implementation priorities. There were certain strategies that either based on data or based on expert input were associated with more effective stewardship programs. And so what we're trying to do is begin to identify a set of implementation approaches that we think are the most effective, or at least more effective, that we want to steer people towards. And so the question becomes, well, how do we do that? How do we both identify those strategies and then begin to draw people's attention to them so that we can make progress in that direction? I'd like to say a little bit about the submission of antibiotic use to the NHSN antibiotic use option. This is definitely an area where we have seen a lot of growth. We've got nearly 2,300 hospitals that are submitting data to the NHSN antibiotic use option, representing all 50 states and representing a variety of bed sizes. There is a little bit of a skew towards larger bed sizes, but we do have more than 200 critical access hospitals, as you can see at the top, that have submitted data to the NHSN antibiotic use option. So that, again, is a real victory that we have such a large number of our critical access hospitals that are submitting data. I'll just share with you a little bit of what this data looks like. This is data by quarter showing the standardized antimicrobial administration ratios. And I'm showing you 2019 in the blue bars, so the light blue bars. So that's prior to the COVID pandemic. And I'm showing you 2020 in the darker blue bars. And I'm sorry, I'm going to move this again so you can see this better. And what you can see here is that in general, the SAR values looking over time have gone down a little bit. They're kind of consistently below 1. And the way to interpret this measure, this is like any other type of standardized measure, where 1 means that we're using about the amount of antibiotics that would be expected. Anything more than 1 is more use than expected, and anything less than 1 is less use than expected. And given how much antibiotic use in our acute care hospitals is known to be either unnecessary or inappropriate, we would like to see these numbers kind of move down in the lower directions. And what you can see is that we have made some progress. We do have these ratios that are generally less than 1 for these are broad spectrum community onset agents, is what BSCA stands for. BSHO is broad spectrum hospital onset agents. Those are things like piperacillin, tazobactam, carbapenems, those other types of agents. And then all is, of course, all antibiotic agents. And what you see reflected here is, of course, slightly higher rates of use during COVID. And that's generally true across the board when you compare 2019 to 2020. And that's not unexpected. We had a lot of patients being admitted with COVID, with acute respiratory illnesses, with pneumonia. A lot of those patients got antibiotics. And I think you see that kind of most strongly reflected in the data on the broad spectrum community onset use. Although I will point out that those numbers did stay below a SAR level of 1.0. And so compared to previous years, we're still using fewer antibiotics than would be predicted based on the 2017 baseline. That was data for adults. This is a slide showing data on pediatrics. Here you can see there's a lot more variability in the standardized antimicrobial administration ratios. And that's because these sample sizes are much, much smaller. There are, of course, for the adults, thousands of different locations that are submitting data. When we begin to look at the pediatric side, those numbers drop into the hundreds. And so we do see a little bit more variability. And so you see a lot more movement between 2019 and 2020 when we're looking at the SAR values. There are a number of different values that are significantly higher than 1, especially for the broad spectrum hospital onset agents. So we think there's an opportunity to learn a little bit more about the types of antibiotics, the way that they are being used in the pediatric settings, particularly intensive care units, to see if there are places where we can make progress there. And this is just summarizing the SAR values across all of the different adult locations. Again, the general level of use is about what we would expect. That 1.0 is antibiotic use at the level that would be predicted. But these box and whisker plots show you for each of these standardized antimicrobial administration ratios, the box shows you the 25th to the 75th percentile, and then the whiskers show you the 5th to the 95th percentile. And what you can see is that for some of these different categories, there's an awful lot of variability in US hospitals. Even for all agents, you can see that we have, if you go from the 25th to the 75th percentile, we have about a quarter of hospitals that are using almost 20% fewer antibiotics than would be expected, and about a quarter of hospitals that are using 10% more antibiotics than would be expected. And some of those differences get even more pronounced when you move into the broad spectrum hospital onset agents. And so when we see variability like that, it doesn't necessarily mean that the low use is good and the high use is bad. However, it does give us an opportunity to begin to explore, to talk to some of these hospitals that are at the extremes to try to better understand what accounts for this type of variability. Is this what they would be expected? Maybe they are using the antibiotics correctly and they just have a patient population that would merit higher or lower use, or do these differences reflect opportunities where we could improve antibiotic use? This is that same graph for pediatrics, again, showing that there is considerable variability between the 25th and 75th, and also between the 5th and 95th percentiles. And again, the SAR measure itself does not say that use is appropriate or inappropriate, good or bad. It only points to differences from what would be expected. And it allows facilities then to begin to explore a little bit more to try to understand why they might be different from what would be expected. This is a breakdown. This is data that's available to all facilities that are using the NHSN antibiotic use option. It's just a breakdown of the different types of agents. And I'm showing you here the graph for the broad spectrum hospital onset agents, just to give you a sense of what antibiotics are being used in US hospitals. And this is both for adults, as you can see, and pediatrics. And what you see in adults is that this very large category of broad spectrum agents generally used to treat more resistant organisms is largely comprised of 3 different antibiotics. There's piperacillin tazobactam, cefepime, and meropenem that comprise the overwhelming majority of this category, with the carbapenems being kind of the smaller representation and the beta-lactams being the larger representation. For pediatrics, there's a little bit more difference. The top 3 are still the same, piperacillin tazobactam, cefepime, and meropenem, but there's a little bit more variability in some of these smaller agents in the pediatric settings. And again, this is only intended just to give you a sense of the different types of agents that are being used in acute care hospitals. But this is the same graph showing you the utilization of what the category that we call broad spectrum community onset drugs. And so these are generally agents, at least in the adult side, that are used to treat things like community acquired pneumonia. And given that, you can see there's a very, very heavy representation of ceftriaxone, both in adults and in pediatrics. In adults, the fluoroquinolones make up the bulk of the remaining agents, and in pediatrics, it is the beta-lactam, beta-lactamase inhibitors, either amsulbactam or amoxicillin clavulanate, that makes up the bulk of the rest of this category. And this is also just showing you that same breakdown of the different agents. Again, ceftriaxone, cefepime, this is for the beta-lactams. So what we are trying to do is now support people who are using the NHSN antibiotic use option to try to figure out what we could do to help them meet targets. You know, a lot of people have said we are using the standardized antimicrobial administration ratios, and we're setting targets for ourselves because we think we can lower our use. But they said, you know, one thing that we like is for our infections, when we want to set a target to reduce our standardized infection ratio, we can calculate exactly how many infections we need to prevent in order to reach that target. And that's really helpful for our providers to know. So what they asked us is they said, could you all at CDC come up with a similar tool for antibiotic use? Because we would love to be able to set a target for a standardized antimicrobial administration ratio and then know exactly how many days of therapy we would need to eliminate in order to reach that target. And so we have done just that. We have a program in the NHSN antibiotic use option that has gone live now. And it's called the Targeted Assessment for Stewardship. And basically, it works exactly as the Targeted Assessment for Prevention worksheet. So what you do is you go in and you put a target into the application, and then it will tell you, in order to reach that target, based on where you are now, you would need to eliminate this many days of therapy. And so this is a tool that we hope will help people reach their SAR targets. The other thing I wanted to say a little bit about was the work that the Joint Commission has been doing on the stewardship standards. And as all of you probably know, the Joint Commission was the very first organization to have accreditation standards for hospital antibiotic stewardship programs. And recently, the Joint Commission standard has been around for a few years. And as we revised the core elements, and as the field of stewardship began to advance, the Joint Commission has said, we probably should begin to lift our standards as well. We need to review the evidence. We need to review experience with implementation, and begin to see if there are ways that we need to move our standards forward a little bit to make stewardship implementation stronger. Ultimately, the goal of their standard is, with any quality standard, is to have the most measurable impact possible. So they have done a number of revisions to their proposed standards and have sent them out for comment, and they're in the process of reviewing comments now. And what you'll see is that many of these focus on the same types of things that we called out in our 2019 revision of the CDC core elements, to try and lean forward into those types of strategies that we think would be most effective for stewardship programs. So this is just a handful of the things that the Joint Commission is considering. They are going to focus leadership action on making sure the stewardship program has the resources necessary to do its job. We know that's critically important, that the stewardship program have resources that are allocated by hospital leadership. Like we were talking about earlier, they are going to focus their implementation strategies on prior authorization, prospective review, and feedback. So we were mentioning earlier in this talk, these are the two most evidence-based implementation strategies. They're also going to really encourage hospitals to focus their improvement efforts on the three most common indications for antibiotic use in hospitals: pneumonia, urinary tract infections, and skin and soft tissue infections. We know that in acute care hospitals in the United States, more than 70% of all antibiotics are prescribed for one of these three indications. And we also know there's a lot of room for improvement in each of these. And so they want people to focus on them. They are going to focus their measurement efforts on collecting days of therapy of antibiotic use. We really do think this is the best measure of antibiotic use, the most actionable measure. And they're going to mention that one great way to do this is to report to CDC's National Healthcare Safety Network antibiotic use option. And they also are going to remove some elements. One of the things they're going to remove is some of the items that they had on education, because they really feel like, education, it's very important, and there's no intent here to diminish the importance of education. But they are also, I think, acknowledging the fact that the ability to deliver and measure the impact of education is very, very challenging. And so they want to measure other things and feel like trying to measure education is not something that they want to spend a lot of time on. We know there's a lot of work that's going on. Even in the midst of the pandemic, people are finding ways to get things done in the stewardship arena. And this is just kind of a summary of some of the things that CDC has been very active in supporting over the last couple of years, especially this last year when it comes to stewardship. And you can see there's a few projects here that are focused on sepsis. We're focused on trying to find ways to give individual providers feedback on their antibiotic use. We know this is very, very important to providers. They want to know how they're doing, particularly in comparison to their peers. So we're working on that. And we're also investing a lot of effort to try to find ways to do electronic assessments of appropriate antibiotic use. As all of you know, the goal of stewardship is not to reduce the amount of antibiotics that are used. It's to optimize the way that antibiotics are used. Now, clearly, part of that optimization is to stop using antibiotics that are not needed. And we know that there's a lot of that happens in our hospitals. But the ultimate goal is simply to make sure that patients are getting the right antibiotic, the right dose, at the right time, for the right duration. And that is hard to assess. It, in the past, has taken a lot of manual record review in order to do those types of assessments. So we are exploring ways to try to do this using the wealth of information that's available in the electronic health record. So I'm going to close there. I think we will have a few minutes to take some questions and acknowledge that, the last couple of years have been really, really tough when it comes to stewardship. Despite that, we have seen a lot of advances in stewardship program implementation as measured in the NHSN survey, which 2020 was the latest year that we have that. And I think it is absolutely a testament to what all of you have done. You have built stewardship programs that really are resilient, even in the face of the pandemic. We did not see in 2020 a drop off in the number of hospitals that were implementing all 7 of the core elements. So those programs that you all built were able to withstand the impact of the pandemic in 2020. And of course, we know that there's more ahead. There's certainly more that we can do. And I would love to hear any ideas that you all have as we think about hopefully beginning to climb out of this pandemic and begin to get back to delivering our normal care. What can we do that does that better? How do we come back in a way that's even better than we were before? So with that, I'm gonna stop and turn things over to Becky, and we have a few minutes. I'm gonna stop sharing my screen. We have a few minutes for questions and for any comments that folks might have.
Thank you, Arjun. Appreciate all the information that you've shared. I did have one question chatted to me. During COVID, we are seeing an increasing number of patients expecting to receive antibiotics when they come in, particularly to the emergency department. Do you have particular resources that you like to share with patients, or do you have particular articles with data that are most effective in working with patients?
Yeah, that's a great question. You know, I'm not aware of a lot of, there are certainly a lot of, well, I shouldn't say, there are a lot of resources, outpatient resources that are available on the CDC website. If you look at the website on antibiotic stewardship programs, it's called under the title, the Be Antibiotics Aware. There are a number of different patient resources there. There are some fact sheets that you can download. There are prescription pads that you can download for non-antibiotic interventions. So I think there are some really good resources there that you can use to help people understand that not getting an antibiotic is not a failure. It doesn't mean that they don't feel poorly, but there are some suggestions for the types of things that they can do to help themselves feel better when an antibiotic is not indicated.
How about approaches with patients that providers can use that seem more effective? Do you have suggestions on the manner in which they go about it?
Yeah, one of the things that some of the work, and there has been some really nice work that's been done on this, and they've said that one of the ways that we can approach this as providers is when we interact with patients is not to make the assumption that a lot of times as providers, we do assume that a patient wants an antibiotic. And one of the reasons we assume that is because they will come in and say, oh, doctor, last time I had these symptoms, I got an antibiotic and I got better in right away. And the provider hears that as, oh, you're now asking me for an antibiotic. You're expecting to get an antibiotic this time. And they've done some work where they've interviewed patients in those situations, and the patient has said, oh, no, I thought my doctor would want to know that. I thought that was important information to share about my last illness. I wasn't demanding an antibiotic. I wasn't expecting it, but I thought my doctor would want to know that last time this happened to me, I got an antibiotic and I got better. So this, body of work suggests that when people say that, don't interpret that as your patient necessarily asking you for an antibiotic. They may just be trying to convey information to you.
Thank you. That was helpful. Another question that was chatted to me, are there any types of resistance that we might be expecting in the future to increase?
Absolutely. We certainly are seeing an increase in the United States in the presence of extended spectrum beta-lactamase producing organisms. So these are primarily gram-negative organisms like E. coli and Klebsiella that are resistant to all of the beta-lactam antibiotics. And they really require, in many cases, carbapenems for treatment. And over the last few years, we have seen quite an increase in the presence of those organisms in the United States. And so that is a worrisome trend that we are certainly monitoring.
Okay, thank you. I know that you do have to hop off for a meeting that you were called into, so we will be cutting today's presentation a little bit short. I do know that Dr. Srinivasan's very interested, though, in hearing your challenges. challenges with NHSN. So Arjun, I don't know if you have heard of any recent challenges that have been discussed more recently that you'd like to share and how people could overcome that.
I haven't, and we're always interested in knowing, as you said, challenges you've had, opportunities that you see. We are always eager to talk to people who are, doing the hard work of improving antibiotic use to better understand how we can be helpful to you. So please do feel free to email me, email Becky if you don't have my email address. Becky can certainly share it with you. But I'd love to continue to stay in dialogue with all of you in Indiana. This has been such a wonderful collaboration. I've learned a lot from all of you and would love to continue to do that.
Well, thank you so much. We really appreciate your time today. We know how very busy the CDC is right now and how very busy you have been over the past couple of years during the pandemic, and really appreciate all of the support the CDC has provided the country. So again, questions, send those to me. I will work with Arjun. And if there are concerns that you have or challenges that you're facing that you would like some guidance on, why we would be glad to help you. Annette Handy with the Hospital Association and Karen Kennedy are also great resources here. And so we'll all work together to try to make your lives as least cumbersome as possible and try to be really good resources for you. So take a little time back today, and thank you so much for joining. We appreciate sincerely all you're doing every day and certainly understand how tired and overworked everyone is. But thank you for your dedication and have a wonderful rest of your day. Thank you so much. Bye-bye.